So I need a disclaimer slide. It's going to get worse. So this kind of looks like a sign in the neighbor's yard, but I won't talk about that. Okay. And in my yard, too. So, yeah, this does not represent National Academy of Sciences or Northwestern University, just me. So, again, I want to, again, thank you very much to Lila, to the National Academy of Medicine, to have me here closing. Great way to keep me here and just not focused, is to put me at the very end. Yeah, it's like, much like a 4-year-old, you need to corral me. Anyway, I'm really happy to be here and to close out a really great day and to talk about work that with Ruth and with Terry and with Will and many of you here, and I will not, I want to make a special comment to thank Cindy Brock for being the greatest advocate for a lot of the work that's been talked about today. I don't think people really appreciate how much we do, and we know, I mean, honestly, and to those of you who know Carolyn Clancy, who, and I know you don't like it when I say this, but she referred to you as a wonderful bulldog because you were an incredible advocate for this work, and so again, thank you very much. Great, well. Some disclosures, not disclaimers, but disclosures here for work that for the Health Literacy and Learning Program that I lead at Northwestern University and also have a few colleagues in the room for. So, you know, I was just thinking about this meeting, and this is almost exactly a decade ago that we launched in this building, actually, the conversation. Actually, it was the other building, I believe. Sorry, yeah, sorry, yeah, would have been great. You know, this workshop that really started thinking about standardizing medication labels, and in that, you know, we presented a lot of this work from a white paper that was funded by the American College of Physicians Foundation at the time. And it did expand beyond just the container label. We did talk about a lot of the materials, the leaflets, the general, as Ruth would refer to it, the lack of a system of information that we have yet to kind of see, and kind of coordinating all this information beyond the 2-inch by 4-inch label that may be attached or affixed to a 30, 40 dram vial that we're normally expecting to think that's all we need to know. And that really launched a great amount of research. And so in kind of what I thought was my charge for today is to kind of maybe not just look back, but look forward into where are we going. I did want to summarize at least some of the work today. You know, in terms of what we've learned. And I am from Chicago, so, you know, I had to sneak this in somewhere. And yes, finally. And I hope we don't have to wait 108 years to see some of the things that have been presented today come to light. And so I do focus in on scalability and I get nervous when things can't move forward. But, you know, we have built a sizable research evidence base in a great amount of time. And even Will Schrank earlier this morning, kicking off the meeting, mentioned, you know, the 100+ studies that he summarized in a systematic literature review that was published in Annals of Pharmacotherapy in, I believe, 2009 or 2008. Actually, one of our colleagues, Rebecca, in the back, can probably highlight that date better than me. But, you know, in that point, even launching Thinking Past It, I think there's at least 3 systematic reviews that have since kind of reviewed everything since Will. Colleague Stacey Bailey at UNC Chapel Hill published again in the same journal, Annals of Pharmacotherapy, a lot of research with, unfortunately, a lot of gaps still existing. But again, I think we've really come a long way, again, thanks to the likes of Cindy and, you know, and many people who have really fought in the industry space as well for really getting us moving to kind of solve this. It really has been, I think, really unprecedented. I also want to thank the FDA for really getting engaged on this. And in fact, the year before the IOM meeting, there was a fairly large workshop in 2006 that the FDA put on to really start to figure out and ask questions like the fact that we have multiple documents that come out with the prescribing medication, and you know, does it have to be a single page solution or a single document solution? And that has continued on and led by the Brookings Institution, now the Duke Margolis Center. But you know, there's a lot of great work, and also a hat tip to the USP, which has many of us have worked with, and I know Donna's in the audience, that has really brought together and synthesized and tried to give us a single place to put all the evidence base of what we know that is relevant to prescription drug labeling and communicating clearly about medicine. And so I think that these are things that we need to really cherish and really appreciate, that we have done a really good part in trying to find a way to pull things from lots of different fields that are relevant to try to solve this problem of doing a better job of communicating to patients. Exciting to hear also today, about the continued expansion of policy reform in several states, because, and I think we've heard this earlier, it's really the action is in the states, right? State boards of pharmacy coming together to rally to get some very meaningful change in trying to get a better label to patients, get better information. And so what's happening in Wisconsin, what has happened in California, what has been started, I know Shauna has been doing many things with the Northeast, I think we need to keep going. We've gotten a lot of support also from the National Association of Boards Pharmacy, but again, we're not there yet. And then just really, as you've seen Merck pop up a million times today, but also with the work with AbbVie, with Jay, with United Healthcare, you have a lot of great examples of not just engagement, but high-level engagement of people who are really taking the charge to try to find a way to do better. And I think, especially in this space, we're not developing the drug, but we're actually just trying to figure out how best to help people use the medication, that we all see it's a good win. So anyway, I think it is important for us to recognize that we've done a lot of good in a short period of time. At least I'm hoping that, I think 10 years, at least for me, has felt not so long. I'm hoping the next 4 will feel even smaller. So anyway, health literacy, some issues. I just want to summarize this again to move forward. I wanted to really, there's a lot of an expansive literature, but there's just a few takeaways that you really need to really zoom in on, because this is where I think health literacy intersects with the medication misuse, the medication poor adherence issues, where people need more information, what exactly are they really struggling to understand. And the evidence, again, that I've seen, at least cultivated from this expansive literature, is really the problems that are focused around health literacy are around, one, reconciling medicines, knowing what they're taking. So knowing indication for use, knowing what the expansive medications are, yes, talking about pronouncing drug names. Those issues, though, that really interface with the health system, that create discrepancies between what the provider knows and what the patient is actually taking, that is a major component, as well as spacing out multi-daily dosing medications. That is also a major issue we've understood. Remembering to take medication. Again, it's beyond the comprehension of just knowing about your medicine, but it is the behavior that we've seen more times than not materialize that lower literate patients, less health literate patients really struggle with, that forgetfulness factor. So I'm just trying to lay out what we see in the evidence. And again, what I think a lot of the work that we've done has been focused on organizing complex drug regimens, that it's also integrating multiple medications. So it's not just one drug at a time we're thinking about, it's how do you educate people about a regimen, not a medication. And then it really gets to a lot of what we're talking about with leaflets and general information, not just the procedural content you're just trying to convey on a 2x4-inch label, but how do you help people problem solve and just think about their medicines and make good decisions outside of the point of care. And that really is also where we're really finding the challenge. And what matters and what outcome, I kind of threw that in as the title because this is a very fresh off the press systematic review by Wally in Canada, actually, where they did take an examination to look at what is the state of interventions to improve medication information for low health literate populations. Really fresh, right? So this is important, but this is what they found. They categorized 6 types of interventions, and I think they pulled in somewhere in the ballpark of around 50 studies that counted about this. And the medications were grouped as written and visual and audio, or basically audio-visual or audio-verbal, so spoken counseling type strategies, labeling, reminder systems, and educational programs. What I can tell you about these 6 buckets of interventions that they've said is, again, the majority of the evidence is mediocre quality, which is a big problem that we really have to get over. We can't do these. We have to get the support of strong, rigorous research because it's also one of the reasons why we're stagnating. But across these boards, and each of these interventions, there's a common theme that you have about a half to 2/3 of interventions that fall on each of these. And really, if you think of them in hierarchy, that most of the studies are on written interventions, while the fewest are more on like text reminder interventions and so forth. But in each of these buckets, half the studies were successful in showing improvement, half to two-thirds. And then among those studies, though, what they improved mostly was comprehension. And maybe a fraction or a little bit more than a fraction were focused on adherence or behavioral outcomes. So I think this was a kind of a glass half full. Things seem to work if we can kind of if we can buy into some of these interventions. But what they did show is that what makes the interventions that did work successful is that they weren't single interventions. They were interventions that were supported by other sources of materials. You didn't just rely on someone learning spoken counseling, you were getting spoken counseling and supportive written materials. You had tailored or personalized information that also was beneficial, and interventions that targeted health systems to ease navigation and simplify accessibility of the content also were the most successful. So that's just kind of a quick highlight over a large amount of research, and again, since it's so most recent, I thought it was a good way to, again, just looking back, and we'll move forward in a moment. Again, the support that Terry and Ruth and I, along with our colleague Alistair Wood, really received, that was first presented a decade ago at the IOM, this universal medication schedule idea, which was the idea of simply writing instructions more explicitly, morning, noon, evening, bedtime. The simple, basic construct that actually was even supported with evidence even before the name UMS kind of got mentioned. And this is coming out in 2 weeks. Again, an ARC-supported trial, advocated and supported and sponsored by Cindy, was coming out in JGIM. I'm going to say your name several times, so you just, at some point I had to give this to you. It showed, this is the thing I liked about this study, is because here's a great evidence-based practice that I think that we just need to figure out how to do better, because it is has a modest effect, a very modest effect in the general population. I'll just say that. It's a health literacy intervention that just does something very passively, but yet among high-risk groups, those with more medications in their regimen, those who had drugs that required multi-day dosing, not just once-a-day dosing, and those with limited literacy skills all received the greatest benefit, significant benefits. And when you put it to scale, and given how low cost something would be just to change out how you write an instruction, there's going to be major cost benefit. So a few important takeaways of the evidence to date, for looking back to what we now know that are important, I think, for this field, is one, plain language and written prescription drug labeling alone has limited ability to reduce literacy disparities. That's just a statement. It doesn't mean that we shouldn't be doing it. Of course we should be doing this work, but we have to recognize, and here are 4 studies from our research team, Terry, Ruth, and I, that one interesting finding across all of them, whether we're targeting auxiliary warning labels or prescription dosing instructions or medication guides, across all of these types of interventions, the one thing we found is that, guess what? Our interventions, doing something enhanced, a health literacy approach, significantly improves outcomes. But the benefits are across all literacy groups, and the disparity between the highest functioning literate patients and those with the lowest literacy skills doesn't really shrink. We don't narrow the gap. We do support people with marginal literacy and actually make a significant, cut that disparity between high and marginal literate patients by half. But again, you're not going to actually get the benefit you need doing this modality, written material, if you can't read very well. It just makes sense. Variable content for prescription medications still exists, and I've heard this mentioned several times today. We need to get past this. It's just an amazing thing that we can't find a way to have standardized content about what needs to be known about a particular medication, because then we can start having the conversation about how to improve it and then how best to disseminate it. So the fact, though, that we are, depending on where your approach, your entry point into the healthcare system, and what health system is, what educational material and how they're developing it still varies so, dramatically, really is a major hindrance for moving forward with some of our interventions. We also know from studies, whether you're looking at an article by Lou Morris in the 1980s to something that happened last year, rates of spoken counseling on prescription drug medications have been pretty stagnant. We still have a major problem of getting actual communication about medications to occur during encounters. And that is a major challenge when even what we said 10 years ago is that all this work we're talking about in written form is not to replace what happens in that relationship between the provider and the patient, and yet we have not been able to target that very well. So that, again, needs to be solved. And again, to highlight, multifaceted communication strategies are going to be needed, so we need something to get beyond just the written forms, or even if it's a digital space. We need to have providers engaged to be able to make some really meaningful changes to patients' learnings about their medicines and their ultimate behavior with medicines. So moving forward, because I have to go kind of quickly here, is we need to be setting standards, and I think the USP has really launched us in a great way for the written material, but I think we do need actually some more work on how that translates actually to how we develop and disseminate and design digital tools that communicate information and support patients' behaviors around medicines. I think that, and I want to highlight a few materials. These are not specific to medications, but these are documents that are wonderful resources. Again, we know how to do these things. We have evidence from the doke and root. We've got evidence even before that and much past it that is summarized nicely, including what you've already done here at the IOM, on how to better design written material so it just goes in place, that we know what the evidence base is. And we even, thanks to ARC and Cindy, God, you're just going to get a lot of it today. With the PMAT, I really, really wish we had a different acronym for that. I am sorry. I'm going to say that till the end. But you have resources to not only guide you in the development of new material for medications, but also on how to evaluate existing sources just to figure out how can you improve upon them. So I feel like it's just, again, getting this out and just moving past it so we don't still have these conversations on what font size should it be. Bridging the many divides is just, it's really going to be very, very challenging when we also know that the system is also one of our greatest kind of adversaries in terms of trying to get beyond and give people good information about their medicines. And a lot of it gets at how do you get a physician to be able to communicate or even coordinate well with a pharmacist when we've shown lots of times there's kind of a lot of voltage drops in terms of the interventions and that we've been trying to work on to get either one of them to speak well about their medications, but also there's a divide, electronic divide, in terms of information sharing that really gets at the major critical problem for us. If we're not Kaiser, for many of us at Northwestern, we do not have embedded pharmacies in place, so we cannot create interventions that coordinate between the prescriber, who could then be reinforced by the pharmacist at the dispensing end in terms of making sure that what's said by the physician can also be reinforced by the pharmacist, in that they both can be providing adequate support to counsel patients. So part of the solution, and again, I don't know what happened here, but again, subliminal message, is that the electronic health record might be the point that really does solve. Am I going to get in trouble for this line? No. So it's the electronic health record, and Dan made a comment earlier about this, that we really need to be able to figure out how to coordinate and have the systems talking between the pharmacy and medicine about how best to get these the information sharing. In fact, we were working in a partnership with Walgreens and United Healthcare to figure out how could we leverage technology to allow pharmacists to provide support, comprehensive medication reviews, and education to clinics, if that were possible. If in fact they could actually just to see the medication list and have access to how patients get the medical record, and that is a challenge. So again, moving beyond what is written, I'm just going to be very quick here. Interesting review in 2016 of 16 current trials that targeted medication adherence by using text reminders. The average, just a simple ongoing text reminder service, again, moving to behavior to remind people when to take their medicine, had on average a 2-fold increase in adherence rates. By doing something so cheap and easy as is giving people a reminder when to take medicine. Finally, patient-centered design is also needed, though, because if you want mobile technology to do more than simply send you a text message, The smartphone applications, again, they're in abundance. We did a review, Stacey Bailey reviewed this in Jamia a couple years back, that we found over 14,000 health-related apps, drilling down, found about 400 self-management apps for medications, and basically just looked at user reviews versus to find out what exactly are the systems working and what aren't they working. And a lot of it just comes to say that these are not patient-centered design, that we're so quick to develop these apps, but we haven't involved patients, and that's a common theme that we're learning right now is how well do we design involve patients in the development of these tools so they actually meet the needs that patients, the barriers that patients are facing. And finally, I'm not going to spend a lot of time because I'm out of time, there's a few tools that we have been working on right now that do get to the electronic health record issue that Dan brought up earlier. It is a linchpin for us that we have been able to leverage on multiple studies now that are under review and also actually engaged and funded. And this is a project we're doing with Eli Lilly, where you can actually prompt physicians with best practice alerts to fire when medication is ordered, to give them the counseling guidance on what to say to your patient. You can generate patient medication information upstream at the point of prescribing a medicine and not just at pharmacy by having an automatically generated link to the medication order with an after-visit summary. You can email patients with a portal, or you can do phone calls with interactive voice response. However you think you can reach patients, to ask patients to complete and report back in beyond the point of care on the encounter on how they're doing with their medication, if they have problems, if they've missed doses, if they're experiencing side effects. All of these things can be done, and here's an example of a BPA for Tradjenta. Here's a medication guide that can be generated that follows best practices in health literacy that we published in Medical Care a few years ago. Here is an email invitation to have patients go to their portal, and again, the big challenge I'm not talking about is people aren't going to the portal. But again, the reason they're not going to the portal is we have not given them any functionality to any reason to do so. So this is one example maybe to have people then quickly respond to a series of small questions on how are you taking medications? Did you fill it? Are you taking it? Did you stop taking it? Did you miss doses? Are you experiencing side effects? Submit. And then even to provide behavioral lab reports back to physicians to say, hey, here's a problem. And I think that is where I'm thinking about with building a system. I'm going to skip here because this is a little bit more involved and I'm out of time. But again, I'm hoping we don't have to create medication leaflet toilet paper. But there's a lot of interventions and innovations that are out there that are wonderful, and some that are absolutely horrible, but I give them an A or an A minus or maybe a B for trying. But again, quoting another great person, it is common sense to take a method and try it. If it fails, admit it frankly and try another, but above all, try something. That is the message I feel right now is we need to just get out of the way of ourselves to just start doing something. And to know that we can evaluate it, and if it doesn't work, we can learn from it. But I don't think we're going to be doing in a worst case scenario than something worse than what we're already doing right now. So thank you.